As I'm sure everyone knows by now, Bruton's tyrosine kinase, or BTK, is an outstanding therapeutic target in chronic lymphocytic leukemia. Most of the longer-term data is with the first-generation agent ibrutinib, but it's really just an outstanding therapeutic target. The issue is there's a lot of side effects with ibrutinib, and that's actually one of the main causes of treatment discontinuation. So the BTK inhibitors have to be dosed indefinitely, but for a fraction of people, ibrutinib isn't tolerable. So acalabrutinib is a next-generation BTK inhibitor that binds actually irreversibly to BTK at the same binding site, but is more selective. So if you look at the kinase map, it is more specific for BTK and has fewer off-target effects. Because of this, we hypothesized that it would work very well in patients who didn't tolerate ibrutinib. So this study we did is a phase 2 study that was specifically in patients who had discontinued ibrutinib due to poor tolerance of the agent. So for adverse events, so this is not looking at an ibrutinib resistant population. So it's not people that progressed on ibrutinib, that's different. But in these intolerant patients, acalabrutinib was actually very well tolerated, and we only had 7 of 60 or 12% discontinuation for adverse events. So that might sound high, but when 100% had discontinued ibrutinib, really 12% discontinuing acalabrutinib is really quite good. And the efficacy was very good too. So the overall response rate, if you include partial remissions with lymphocytosis, was 77%. So that's also demonstrating that hitting this target is still effective in these patients, but the agent is tolerated specifically in this population. So I think there's kind of two potential future implications for this. One of them is, while acalabrutinib, at least in the United States, is not approved by the US Food and Drug Administration for CLL yet, although there's new data out in the relapse refractory population that hopefully it will be soon. It is approved for mantle cell lymphoma and available for off-label prescribing, and based on this data that I'm talking about and another cohort of ibrutinib-intolerant patients, this is in our major guidelines. So I would argue that acalabrutinib can already be considered a standard of care for patients who don't tolerate ibrutinib and are responding and still continue to need CLL therapy, even though it's not approved for that indication. But I think what's really the other kind of implication is that for patients that you say, for some reason, ibrutinib is unlikely to be tolerated, so patients needing a lot of blood thinners and are having bruising, patients with atrial arrhythmias, patients with hypertension. So there's some patients with CLL where you really think, boy, a BTK inhibitor would be an outstanding choice, but you're just looking at someone in clinic and you're saying, based on side effects, I don't really think that this is going to go very well. I think there's definitely a role for acalabrutinib there. In the both the frontline and the relapse refractory setting, there's certainly sufficient data to support its use. I don't know that another study in the specific population is warranted, but I do think that the ongoing randomized phase 3 study in relapse refractory CLL that's comparing ibrutinib to acalabrutinib directly will be very helpful. You get to see if there's any difference in efficacy. The primary endpoint is PFS, but you will get to see side by side the adverse event profiles of both these agents in a randomized setting. So I think that'll also help us understand better the difference in side effects between these agents. And I think that individualizing patient therapy based on side effect profile is really important, because if patients don't tolerate it, then they're not going to benefit from it.